طيب، صباح الخير يا شباب، اسعد الله صباحكم جميعا. بنكمل موضوع اليورينري انكونتيننس، وحكينا المره الماضيه عن التريتمنت اوف يورينري انكونتيننس، وبنكمل اليوم على الامريكان يورولوجيكال اسوسيشن جايد لاين فور تريتمنت of overactive bladder, or we call it OAB, overactivated or overactive bladder in adults. So we have a first line therapy, we have a second line therapy, and we have a third line treatment for this. So in this table is taken from the chapter number 85 in the book. So the first line treatment for overactive bladder in adults is behavioral treatment or behavioral therapy, such as bladder training, bladder control strategies, pelvic floor muscle training, and fluid management. And on the second column to the right, you will see the evidence strength grade. So they are graded between A, B, and C. A is the highest, but we don't have any A's over here. Then B is the moderate evidence or strength evidence. And C is the lowest evidence. So this treatment, behavioral therapy, it's kind of an evidence B, while behavioral therapies may be combined with other anti-muscarinic therapies. This is considered category or evidence C, when C in this case is the lowest strength grade, which means we have less data to support that therapeutic approach. The second line therapy for overactive bladder, according to the AUA guideline, is oral antimuscarinic agents or beta-3 adrenergic agonists. They are considered as second line therapy. And if the patient, and of course you will hear me a lot of times today talking about immediate release versus extended release or long-acting drug or a preparation. So sometimes you have both are available. So if you have the immediate release or the IR formulation and the ER, which is the extended release formulation, so prefer the extended release formulation because of the side effect profile. So we will have lower incidence of adverse events or side effects due to the use of extended release as compared with immediate release. And specifically, if we're talking about the anti-muscarinic agents, we're talking about dry mouth. One of the second line treatments, also one of the options, is the transdermal oxybutynin. We'll talk about it in more details in a few minutes. The transdermal oxybutynin patch or gel, both they are applied on a skin. I mean, both, it means either or. May be offered also, but the support or the evidence that we have is grade C, which means lower, efficacy or evidence on their benefit. The third line treatment for overactive bladder is intradetroser onabotulinum toxin A, 100 units, in carefully selected patients. So this is not a good option, as you see. It's not the first or second option, it's the third option. And again here, B/C is the evidence strength grade because you have to make a balance between the risks and the benefits, or risks and the burdens of a treatment. So in this case, 100 units is carefully given onto carefully selected patients who have been refractory. Refractory, it means they did not respond well to the first or second line therapy. Then you will have that option. The third option is to give them the botulinum toxin or onabotulinum toxin A. Another option for as a third line therapy, also peripheral tibial nerve stimulation in a carefully selected patient population, and the evidence is C, which is the lowest. A third option would be sacral neuromodulation in carefully selected patients. As you see, we use this frequently, this term, in carefully selected patients. So not every single patient would be a good fit for this therapeutic approach. So the overactive bladder symptoms in those patients who are not candidates for second-line therapy or first-line therapy, then we will have to use this method, or they don't prefer or they are not willing to undergo a surgical procedure, then we will have that option. So in conclusion, the recommendation according to the American Urological Association for overactive bladder, we have first line treatment, behavioral or behavioral plus antimuscarinic, second line oral antimuscarinic or beta-3 agonist, and again the transdermal oxybutynin also might be available, whether it's a patch or a gel. And we have a third line, which is intraretrosal onabotulinum toxin A, or nerve stimulation, or sacral neuromodulation. So we'll have three different options or lines of treatment, I mean. Now, what about the dosing of these medications approved? I will start with the drugs approved for overactive bladder, AOAB, or urge urinary incontinence. And again, I would like to classify them into groups or classes. The first class of drugs is the anticholinergics, antimuscarinics. And the very common example is oxybutynin. And again, please pay attention to the first column where you will have different formulation of the same compound. For example, oxybutynin immediate release. We have oxybutynin long-acting, XL, oxybutynin transdermal system or transdermal therapeutic system. The brand name, I don't care about the brand name for now. And the dose, I don't want you to remember the dose or to exactly know the dose, but at least you need to know if this is the lower dose or the higher dose, and which one do we start with. In most of these drugs, as a general rule, we will start with the lowest dose and then we will titrate, and we'll usually increase the dose up to a maximum daily dose after a certain period of time. So let's take an example, oxybutynin immediate release or Ditropan. It's 2.5 milligram twice a day. Then this is the initial dose. Then we will have something called usual dose or the maintenance dose. So you will have the opportunity to increase that 2.5 into 5 milligram 2 to 4 times daily. So you will see the difference now. And in the next column, sometimes if there is a special population, I will talk about it. And then there is a comment at the end. So I'm not going to read everything, but I will highlight the most important items in these tables. So then you titrate. The titration in case of oxybutynin immediate release is in increments of 2.5 milligram every 1 to 2 months. So as you see, the titration is kind of slow. So you will start with 2.5 milligram twice a day. Then you will, after 1 to 2 months, you will increase that dose gradually. The next time you will use, let's say, 5 milligram for another 1 or 2 months. Then you will increase to 7.5. And what that incremental increase depends on, it depends on the response. If you get partial response, then you will increase the dose. You need a higher dose. And it's also governed by the appearance of side effects. If the patient cannot tolerate the side effects, then you will have to stop escalating the dose or increasing the dose. The next formulation, oxybutynin XL or the long-acting, normally the dose is higher. So it's 5 to 10 milligram once daily because of the frequency is less. And the usual dose, you will go up to 30 milligram once daily. Then you adjust the dose in 5 milligram increments at weekly interval. And as you know from your pharmaceutics and drug delivery systems, all of the enteric coated or long acting or extended release or these kind of technology in the tablets, normally you swallow the whole tablet without crushing, without chewing. So you should advise the patient to use it perfectly. The third formulation is the transdermal system. Normally it's the same dose. Normally it's going to release the same quantity of a drug at 3.9 milligram per day. The patient should apply one patch twice weekly. So you will have, it's like 2 or 3 days, then they will have to reapply every 3 to 4 days and rotate the application site. The reason for that is to reduce the possibility of skin irritation and erythema. Also, we have oxybutynin gel, gelnek, 1 sachet as a gel بيكون على شكل sachet. That sachet has 100 milligram topically daily. So apply to clean. You should clean the skin before. It should be dry, intact skin, not to a broken or wounded skin. On the thighs, the upper arms, shoulders, and this or topical gel, normally it contains alcohol. So again, sometimes it's available as oxybutynin gel in a bottle. That bottle, it has like a pump. So 3 pumps equal 84 milligram topically daily. And again, the application, as we said in the previous one. The next anticholinergic, antimuscarinic is tolterodine immediate release. It's 1 to 2 milligram twice daily. So if the patient, here there is a drug-drug interaction with CYP3A4 inhibitors, because of the inhibition of the enzyme, then the drug concentration will go up, especially if the patient has renal or hepatic impairment. Then here I will have an overdose. Overdose will cause a lot of complications, especially with elderly patients. The next one is a trospium chloride immediate release. Again, usual dose is a 20 milligram twice daily. There's no initial dose. This is given once daily if the patient is 75 years old or older, or if they have creatinine clearance less than 30 milliliter per minute. So the recommendation for trospium chloride is to take it 1 hour before meals or on empty stomach. And elderly patients who are more than 75 years old should take it at bedtime because of the drowsiness and dry mouth and the side effects that normally happen. So again, we'll continue with the table. Trospium chloride, also I'm not going to read everything. I will let you guys read it, but all of this information is needed, of course. Trospium chloride, we have extended release. Then we will have sulfenacine, is also among the anticholinergic drugs. We have darifenacine extended release in Ablix. And we have physotyrosine. We will talk about them in more details in a few minutes, of course, most of these extended release, but this table is summarizing all of this. Mirabegron extended release also is one of the beta-3 adrenergic agonists. It's not belonging to the anticholinergic drugs. These drugs, whether they are antimuscarinic drugs, as you see here, or the beta-3 adrenergic agonist, we need to do kind of monitoring for the medication. Monitoring, again, for 2 purposes. The first purpose is for efficacy of the drug. Am I getting enough efficacy out of this drug? The second option, or the second target or goal, is to monitor for the side effects. So if we talk about the side effects of the first group, the antimuscarinic, you know what the adverse effects of antimuscarinic agents, the anticholinergic side effects, normally dry mouth, constipation, dry eyes, etc. And if they are taken as a topical preparation, you should be worried about the reactions or the local reactions, topical agents, pruritus and erythema at the site of application. The contraindications and the precautions, again, it's exactly the same as the anticholinergic drug contraindications and precautions. And the comments, again, you need to select your patients, and whatever applies to anticholinergic drugs is applicable over here. The next agent is mirabegron, which is the beta-3 adrenergic agonist. Among the side effects is hypertension, nasopharyngitis, urinary tract infection, and headache. And again, the precautions that what you need to monitor for urinary retention, severe uncontrolled hypertension, and worsening of renal and hepatic impairment or condition. Again, you should be careful about drug-drug interaction. A lot of these agents, they have drug-drug interaction with CYP enzymes or the cytochrome P450 inhibitor enzymes. So I will take in more details the oxybutynin immediate release tablet, which is the oldest and least expensive treatment for urge urinary incontinence, UUI. But the side effects of oxybutynin as anticholinergic drug, it might cause substantial non-urinary antimuscarinic effects like orthostatic hypotension because it reduces blood pressure, sedation due to alpha adrenergic block, weight gain due to blocking the histaminergic receptors, dry mouth, and dry mouth can be improved. So your recommendation for the patient is to take a sugarless hard candy so they can chew on that, maybe taking a gum or saliva substitute, artificial saliva. In case of constipation as a side effect, so your recommendation to keep the patient hydrated, take plenty of water, dietary fiber, physical activity, or laxative therapy may sometimes be used in this case. The disadvantage of the immediate release oxybutynin here is the complicated dosing regimen. So especially if you have a patient with cognitive impairment, the patient has polypharmacy. Some patients, they might be taking a lot of medications. And the second one disadvantage is the compliance issue due to side effects and complicated dosing. So some of the patients might have a compliance issue. So to optimize tolerability of immediate release oxybutynin, so again, the dosing should be initiated at 2.5 milligram twice daily. Then you gradually, after 1 to 2 months, you increase that into 2.5 3 times daily. Then you titrate in increments of 2.5 milligram every 1 to 2 months until the desired response or the maximum recommended dosage is achieved. Again, you will have to monitor for efficacy of the drug, and you need to look at the side effects, of course. The next formulation for oxybutynin is the extended release or the XL formulation. This is normally used in people who are not able to take the immediate release or who have tolerability issues for that. They cannot tolerate it. So this formulation would deliver a controlled amount of oxybutynin over a 24-hour period. And another advantage has a reduced first pass metabolism in the liver. And again, the studies they found, a short-term study up to 12 weeks duration, they found the oxybutynin long-acting was better tolerated than the immediate release, with approximately 7%, only 7% of the patients discontinued the drug because of the adverse effects, of course, compared with the 27% in the immediate release formulation. So the discontinuation due to side effects in the immediate release and the long-acting, but long-acting was better tolerated in this case. So in short-term studies also, they found oxybutynin long-acting was at least as effective as tolterodine immediate release or long-acting formulation in managing these urinary symptoms, and it should be administered as once daily. Most of the times the long-acting is given as once daily dose, and again should not be chewed or crushed you have to take the pill as a whole. And elderly patients should always start with a dose of 5 milligram once daily and titrate gradually until you reach the desired effect. So oxybutynin, the extended release drug formulation, also it interacts with other anticholinergic drugs. So you should be careful if the patient is taking other anticholinergic drugs. If the patient is taking cytochrome P450 and specifically the CYP3A4 inhibitors like itraconazole, miconazole, erythromycin, and clarithromycin. These are enzyme inhibitors. So by inhibiting the enzyme, they are increasing the plasma concentration of oxybutynin, then you will have an overdose. And another drug-drug interaction with acetylcholine esterase inhibitors, but that drug-drug interaction via pharmacodynamic antagonism, not pharmacokinetic antagonism. It's just the effect is the opposite. So therefore, we call it pharmacodynamic antagonism because of the opposite efficacy of both the drugs. So if the patient is taking acetylcholine esterase inhibitor, that will counteract the action of oxybutynin, which is anticholinergic in this situation. The next formulation of oxybutynin is the transdermal oxybutynin. As you see in the picture, it has been approved in 2013 by the US FDA. They approved oxybutynin TDS as the first over-the-counter available to patients. They can buy it to be used in women age 18 and older for overactive bladder. So this option gave the women an opportunity for, especially for those who cannot tolerate the immediate release oxybutynin, or who prefer to take the transdermal delivery route of administration. So again, the advantage of this transdermal patch is bypassing the first pass, hepatic and gut metabolism, which is also giving a favorable safety profile. They will have more tolerable adverse effect profile, a more tolerable or more favorable adverse effect. So the transdermal is as effective as oxybutynin immediate release in reducing the urinary incontinence symptoms like frequency episodes and improving the patient's perceived urinary leakage. It's compared with tolterodine long-acting. When we compare it, the TDS oxybutynin provided similar efficacy outcomes, including attaining complete continence and improving the quality of life. إذا transdermal oxybutynin is as effective as the oral immediate release or tolterodine long-acting, so it's kind of comparable in terms of efficacy. So again, as the picture shows here, so the woman can apply it to the abdomen or the hips or the buttocks. So it can be applied every 3 to 4 years, twice weekly. And the recommendation is to rotate the application site at least weekly, may help minimize the local side effects. So your recommendation would be to ask them rotate the application site. Don't apply every week on the same place. The other formulation is the topical gel. As you see in the picture, also this gel can be applied to the shoulder or the upper arm, to the stomach or abdomen area, to the thighs, but this is also not free of side effects. Pruritus might occur. It's the highest incidence. Pruritus, حكة في مكان الابليكيشن. Erythema, systemic side effects like dry mouth and constipation, and abnormal vision. Again, it's an anti-muscarinic, anticholinergic drug, will make anticholinergic side effects like blurred vision. This formulation of the gel, it's available in 10 or in 3%, and it causes significantly less dry mouth than oxybutynin oral administration. So if you compare the dry mouth incidence, it's 6.1%, versus 73 in the oral. So you can see if the patient cannot tolerate the dry mouth side effect of the oral formulation, then they have this option to use the gel, for example. So it's more effective than a placebo. Again, these are efficacy studies, but the side effects, again, still, we have a dry mouth. The reactions on the application site and dizziness might occur in some patients. So therefore, the treating physician and you as a pharmacist, you should monitor for the anticholinergic effects during long-term therapy, particularly in older patients, or we call them frail patients. And another recommendation, especially this is a gel applied to the skin, if the patient is also using sunscreens, then you have to allow 30 minutes before the two. So you have to space them out. The next drug from the antimuscarinic is tolterodine immediate release. This is a competitive muscarinic receptor antagonist. It's as effective as oxybutynin immediate release. It has better tolerability and better adherence. And because it's mainly metabolized by the cytochrome P450, specifically the 3A4, it is elimination may be impaired by inhibitors of that enzyme. Examples of the drug that will inhibit that enzyme and will affect the plasma concentration of tolterodine include fluoxetine, SSRI, sertraline, fluvoxamine, macrolide antibiotics, azo antifungals, and grapefruit juice. Therefore, you should make recommendations about these medications if the patient is taking them concurrently. So you have to reduce the dose accordingly. So the immediate release of tolterodine can be given 1 to 2 milligram twice daily, regardless of food or meals, with or without food. But it's not recommended in patients they have renal impairment, specifically if they have the creatinine clearance is less than 10 milliliter per minute, or if they have severe hepatic impairment. In mild to moderate, they are okay. And the dose should be reduced in 2 milligram to 2 milligram in patients with mild to moderate hepatic impairment. So if they have severe, it's contraindicated or not recommended. But if they have mild to moderate hepatic impairment, you will have to reduce the dose to the minimum, which is 2 milligram. And for those patients with creatinine clearance between 10 and 30 milliliter per minute, and if the patient is taking a potent CYP3A4 inhibitor, you will have to also decrease the dose. So the maximum benefit from tolterodine may take up to 8 weeks after therapy initiation or dose escalation. Therefore, your recommendation in this case, you have to recommend the patient to wait. If they are taking this drug, it's going to take a while until the drug will show the effect. It takes about 2 months. So most probably patients will give up during the first few days of treatment. I'm using this drug, but I'm not getting a therapeutic benefit. So please be patient. Give it enough time to show the benefit. You need about 8 weeks after initial therapy. The long-acting formulation of tolterodine, it's given again as once daily. The advantage is less dry mouth as compared to the immediate release formulation. And it's better than a placebo in terms of the efficacy of this drug, including ability to complete tasks before voiding and patient perception of benefit. It improves the overactive bladder symptoms in men who are taking alpha-adrenergic blockers. We talked about it in benign prostatic hyperplasia. And the dose also, as we said just a minute ago, the dose should be limited to 2 milligram once daily in patients with mild to moderate hepatic impairment. And again, hepatic function, we give it a score we call it child Pew score, A, B, or C, with C is the worst. So if they have mild to moderate hepatic impairment, we just reduce the dose. If they have renal impairment, severe renal impairment, where creatinine clearance is 10 to 30 milliliter per minute, then you will have to reduce the dose again. And as we just mentioned, also the potent CYP inhibitors like ketoconazole, itraconazole, clarithromycin, or ritonavir, then you will have to reduce the dose of tolterodine long-acting. It's similar to the immediate release. Now, if creatinine clearance is less than 10 milliliter per minute, or the patient has severe hepatic impairment, child Pew score C, those patients, they should avoid taking tolterodine long-acting. And of course, the immediate release acting also, immediate release drug. Similarly, it takes about 8 weeks to see the maximum benefit out of this drug after you initially treat the patient. Adverse events and monitoring, similar to immediate release product. The next antimuscarinic drug, physiotolidine fumarate. It's also used for the symptoms of urinary frequency, urgency, or urge incontinence. It's actually a prodrug that gets metabolized into an active metabolite. It's called 5-hydroxymethyltolterodine. So again, we ended up with a similar drug to the previous one. So in short-term studies, this drug showed a better effect than tolterodine in extended release 4 milligram on reducing urge urinary incontinence episodes, micturations, urgency symptoms, and improving the overall quality of life or health-related quality of life. But physiotolidine causes more dry mouth as compared to tolterodine. It's 28, it's almost the double. And constipation is a little bit higher than tolterodine extended release, 4 versus 3%. Therefore, because of these are higher, so it's been associated with higher discontinuation rates due to the side effects that are caused. So it's a little bit more effective, but the side effects are higher, then discontinuation rate is a little bit higher. So if we compare the adverse events between physiotolidine with tolterodine, it's 5 versus 3. And the usual starting dose for physiotolidine is about 4 milligram daily. You increase it gradually into 8 milligram as needed and as tolerated. So as the patient, if the response is partial, you increase it, provided that there is good tolerability towards this drug. So certain conditions or certain patients, they should not exceed the 4 milligram. We said we could increase it to 8, but certain patients, you should not increase it to 8. Again, these apply to severe renal impairment when creatinine clearance is less than 30 milliliter per minute, and those patients who are taking potent CYP3A4 inhibitors. And it's not recommended also for severe hepatic impairment patients. Since this is a long-acting tablet, recommend the patient to swallow it as a whole tablet, not to chew the drug or divide the tablet or crush it. Side effects are similar to the other side effects in the group, included dry mouth, constipation, dyspepsia, and dry eyes. The next drug from this group of the antimuscarinic anticholinergic drugs is trospium chloride and immediate release formulation. This drug is a quaternary ammonium anticholinergic. It's a second generation antimuscarinic agent used for urge urinary incontinence. It has poor bioavailability, or the fraction that reaches the plasma is very small, especially if you give it with food. It's mainly metabolized or cleared by kidneys, and its efficacy in urge urinary incontinence is better than a placebo, but it's less than oxybutynin immediate release. Since efficacy is lower, side effects are a little bit lower, so it causes less dry mouth as compared to oxybutynin. And elderly, more anticholinergic adverse events because of the renal impairment and hepatic impairment in this patient population. So again, they have increased sensitivity to the drug, which is a pharmacodynamic effect in this case. Trospium may interact with other drugs that are eliminated by active tubular secretion via competition, of course, in the kidneys, like procainamide, pancuronium, morphine, vancomycin, tenofovir. So these drugs, they compete for the active tubular secretion. Therefore, if there is no tubular secretion, then their plasma concentration will go up. The dose normally is 20 milligram twice daily on empty stomach because food interaction. And we should reduce the dose by 50% when there is renal impairment, specifically if creatinine clearance is less than 30 milliliter per minute. And in older patients, 75 years or older, the dose reduction to 20 milligram once daily should be considered based upon tolerability. So if they tolerate the drug, then you will use that dose. So the extended release formulation of trospium chloride also available for a once daily dosing. Once daily dosing, efficacy in overactive bladder and elderly on multiple medications. And the pharmacokinetics of this drug include it's mainly secreted unchanged in urine, not recommended in severe renal impairment because it's the main route of elimination, so you would have accumulation of the drug if there is renal impairment. There is some drug-drug interaction with alcohol. It could increase or decrease the concentration with antacids, decrease the steady state systemic exposure when given with immediate release metformin for patients with diabetes. The food decreases bioavailability by about 35 to 60%. Therefore, your advice is to give on empty stomach 1 hour before or 2 hours after a meal. The side effects include, again, dry mouth, constipation, dizziness, dry eyes, flatulence, nausea, abdominal pain. It's typical anticholinergic side effects. The next drug is solifenacine succinate, and this is a second-generation antimuscarinic agent. It's indicated for the treatment of overactive bladder with urge incontinence, urgency, and urinary frequency. It's better than tolterodine in terms of reducing the number of urge urinary incontinence episodes and pad usage, and improving in patients' perception of their bladder condition. So compared with oxybutynin immediate release, solifenacine had fewer episodes, 35 versus 83%, and lower severity of a dry mouth. So the dry mouth effect here is better with solifenacine as compared with oxybutynin. So you can see a significant reduction or lower incidence of dry mouth in case of solifenacine as compared to oxybutynin, 35 compared to 83%. It's a well-absorbed orally drug. The bioavailability is about 88%, which is really very, very good. No effect for the food intake if it's taken with the drug, and it's got eliminated via metabolism and renal excretion of metabolites. The primary pathway for metabolism in the liver would be is the CYP3A4, and the mean terminal disposition half-life for solifenacine succinate 60 to 50 to 60 hours, and the drug can be dosed once daily. As you see, it's a relatively long half-life, and therefore, because of the metabolism through the CYP3A4, then it will interact with the inducers or inhibitors of the CYP3A4 drugs. Most of the common side effects, dry mouth. It occurred similarly between younger and older patients. So you will have similar side effects. The recommended dose for sulfenacine is 5 milligram once daily. And this 5 milligram can be increased to 10 milligram if needed, if there is a therapeutic need, provided that it's well tolerated or there is tolerability towards that higher dose. You also need to decrease the dose to 5 milligram in case the patient had moderate hepatic impairment or renal impairment, and again, avoid the use in severe hepatic impairment. So the side effects, similarly, dry mouth, constipation, urinary tract infection, blurred vision, and there is a prolongation of the QT interval have been reported with high dose. It will cause in the heart QT interval, which means kind of type of arrhythmia. The next drug is darifenacine, and the darifenacine is a second generation antimuscarinic for the management of overactive bladder or urge urinary incontinence. It improves the symptoms and also improves the quality of life of the patient. May be considered in patients who are dissatisfied with the previous antimuscarinic agents. So if the patient is not happy with the side effects or the use of other medications that we have just mentioned, then they have the option to use darifenacine. The mean absolute bioavailability of the 7.5, the 15, and the 30 milligram extended release formulations are 15 and 19%. طيب نكتفي هنا. احنا ان شاء الله بنتوقف عند هذا السلايد، وبتمنى لكم كل التوفيق بالكويز. يعني الكويز راح يفتح in a few minutes، فكونوا جاهزين.